Good morning and welcome to the final session of Thorax. So this is purely clinical, right? So today we'll be talking about all the clinical conditions and it will be covering wide range, right? Right from the say lumbar puncture to we'll be talking about the thorax that is in the form of lungs. We'll talk about heart and so many structures and diseases. So let's start with this clinical part, right? This is clinical part 3. Now see, the important thing would be that many of the points, that's what I have taken into consideration, that over here we'll be discussing many points, and all those points, they are either the part of like USMLE questions or of any of the exam like next. Such questions they can be asked. So over here we'll be very specific, right? The whole idea is to be very specific about when we answer certain clinical questions, and that's what they ask in the USMLE, right? So that's why our focus would be bit from the exam point of view, right? Today, because you have learned the basics, now you're considering that basics are good, so that's why we'll be mounting on the questions, right? So there will be leading questions and that's how we'll be dealing it. So just keep this thing in mind. So here is, we start with some important landmarks, right? These are the landmarks which you must know. Parallelly, what you can do is you can even feel in yourself that when we talk about that this is the highest, this point, right? So just on the skull, as you feel, that is what is called as the external occipital protuberance. Protuberance means prominence, right? So that is external occipital protuberance. And then as you go down, the first feel what you get over there, that is C2, the spinous process, right? The spinous process. Parallelly, you can keep on feeling that external occipital protuberance, there won't be any problem. And immediately, first spine which you feel, that is C2. Then it would be very easy to feel this point, right? This one, this point. This is what? That is the spine of the scapula, right? This one. I'll just zoom it so that it would be easy for you. Yeah, here it is, right? So this one is the spine of scapula, and this final end, that is called as the root. True? That is the root of the scapula. Root of scapular spine, or the root of spine of scapula. These are the landmarks which you can feel easily, and their importance is when you'll be doing any of the procedure, right? So the level over here which you get over there, right? So that would be the level of T3, right? Over here into neck, right? As you'll go down, you'll feel C7. True. Now, another important landmark which is over here, very easy to feel in your body when you feel, right? That is the inferior angle of scapula. Okay? Inferior angle of scapula. So when you feel that inferior angle, immediately you know that you are at the level of T7, right? Now this would be very important because see, you have felt T7 and then you just feel this point. This is what iliac crest, right? That is when you stand in style, so that's your thumb, right? That is on the iliac crest. So that one is iliac crest. You just palpate the iliac crest and the highest point, right? So that is the highest point of iliac crest. So that level is L4, right? L4. So what you now do is, this is one point, this is another point, draw a line and you take out the center point, right? that center point would be T12. If you have so much in your hand, then you'll be able to figure out all the levels very easily, right? So this is like, in nutshell, the important landmarks which you must know. Achha. Though we are dealing with thorax, but some of the part I have taken even from the abdomen point of view because this is necessary, right? As we discuss the spine, so that's why I thought that let me take the lumbar puncture, right? Let me take the lumbar puncture, right? We discuss spine in so much of detail, and in lumbar puncture, it happens that this is a very, very common question that when we do the lumbar puncture, what exactly is the purpose, right? So we say that there are two purposes. One, that you want the CSF examination. You want to take out the CSF fluid, cerebrospinal fluid. Now, cerebrospinal fluid is where, right? That is into subarachnoid space, right? Subarachnoid space. We talked about it. That's the space between the, right? This is just underneath the arachnoid. There is dura mater, arachnoid mater, pia mater. So between underneath the arachnoid. When you want to go for spinal anesthesia, right? Spinal anesthesia. So that is where you have to go into the epidural space. You have to go into the epidural space. We'll see this thing in more detail. Right? Now, this is all theory. The level is either between L3, L4 or between L4, L5. These are the levels which you can puncture. That is, you'll be going through. Why? Right? Why L3, L4 or even L4, L5? Because spinal cord, right? We saw that spinal cord ends at L2, right? So in adult, spinal cord ends at L2. So if you are making a puncture between L3, L4 or L4, L5, then you are sparing the spinal cord. You are not injuring the spinal cord. But do remember, and if you are doing it for a young child, right? Young child. So in that, the spinal cord ends slightly at a lower level, and as age grows, it once again goes at the level of L2. So it is at L3. That's the reason that we have got these two levels. Okay? We don't have to worry about whether we'll be getting the CSF properly or not. Definitely we'll get it because that, say, dilated, because that is a dilatation, right? So that dilated dural sac, right? We'll see the image. That continues till almost S2, right? So it is still S2. So very safely we are taking the CSF from that space where we don't have to worry about whether we'll be injuring the spinal cord or not, right? Will not be injuring it. Whenever you go for lumbar puncture, now I'm changing the color because it is very, very important, right? You need to take care of raised ICT, intracranial pressure, or raised intracranial tension or pressure, right? So in various books, sometimes it would be written as ICT or it would be written as ICP, but basically it means the same, raised intracranial pressure. Now, why the pressure should be raised? Well, we know that this area is filled with CSF, right? Cerebrospinal fluid. So either there is more secretion of cerebrospinal fluid or there is less absorption of cerebrospinal fluid, right? Or if there is any tumor which is obstructing this flow. So there can be many reasons, but how the patient would really represent. See, first, patient will be complaining of headache. Now see what you have to do. I'll be giving you some hallmark that you just can't miss that, right? And clinically also, if you do that, if patient tells of blurred vision, right? Blurred vision, there is vomiting. These are all like cardinal signs, vomiting. And then you feel that this patient is pretty sleepy, right? He's feeling sleepy or his alertness, right? Alertness is pretty low all neurological signs. When you talk with him, you'll find that he's finding it difficult to even speak, right? So he's speak, so the speech, right? Speech is difficult. Immediately, first thing what you have to do, send this call ophthalmologist, right? You have to call ophthalmologist. It is called as the fundus examination. Fundus examination. So with fundoscope, right, ophthalmologist will check for the optic disc, right, optic disc. And if the optic disc is swollen, right, optic disc is swollen, this is called as the cardinal sign, the most important sign of raised intracranial tension. In that case, you should not perform lumbar puncture, right? And technically, it is called as the papilloedema. Papilloedema, right? In any of the competitive exam, these questions they will be asked very specifically, right? So the moment you get the patient headache, blurred vision, vomiting, immediately fundus examination, ophthalmologist will examine optic disc, that is retina. He'll watch the optic disc. Is it swollen? Yes, that is papilloedema, and this would be usually bilateral. Bilateral. Because if it is unilateral, so then the entire diagnosis changes, right? Right now we are talking about raised ICT. Right? So this is what you need to remember very crisply. Achha. Chalo, let's see this. You know, we talked about, sorry, we talked about all those ligaments, right? Ligaments. So there was one ligament like this, right? And we said that this is between two spine. So we said that this ligament is what? It is interspinous ligament, right? Interspinous ligament. So that's the interspinous ligament. Then there were ligaments which were like this, which were over here, right? Over here, like this, right? And we said that this one is all-time great, right? This is supraspinous, right? That was the supraspinous. So it was supraspinous ligament. And once we go inside the vertebral canal, right? So then the ligament which is on the posterior surface of that, and that one is, right? It is like we are talking about this one, right? So just all those things, right? Just for the clarity, I'm marking this. And that was the yellowish ligament, right? That was ligamentum flavum. Correct? Ligamentum flavum. Because when you'll be doing lumbar puncture, you'll be actually passing through all these ligaments. Right? Okay. Now let's have further clarity. This one, right? This one. All the way, it is going, and or let's take this one, right? I'll remove this thing, right? This is what that one is, our dural sac or the dura, right? This one is our dura. So if that is dura, this is our spinal cord, right? That is our spinal cord. And surrounding the spinal cord, there is CSF. So the CSF is over here, the cerebrospinal fluid, and that is into subarachnoid space. So this one is subarach space. Clear? So the needle which is over here, let's say this needle, right? This needle is going all the way into the subarachnoid space, and that's what it is meant for. CSF examination. That is when you want to extract the CSF fluid for the examination. So this is where it will go. It will go into the subarachnoid space, right? So in subarachnoid space. So far, so good. Next one. The second needle, right? The second needle which is passing through the supraspinous ligament, and it is passing through that interspinous, and then ligamentum flavum is pierced, and then it's over there, right? That is our epidural space, right? So that space, this space is called as the epidural space. So spinal anesthesia or the epidural anesthesia, that is where the needle would be landing, right? So this is for epidural anesthesia, this needle. Crystal clear, right? Obviously this is like a sacrum, right, and all those vertebrae. So that's the so that's how they can ask the question that for CSF examination it has to be from subarachnoid space, and for the spinal anesthesia that is epidural anesthesia. How do you know till point the needle has pierced? The thing is that all these distances, right, you see there is the needles are long and short, right? And one important thing, that is what is called as the popping sensation, pop sensation. That is when the dura is pierced, you will be holding the needle like this, and then you will be going exactly like this. So as you pass through, because that's why you need to know the anatomy very well as you pass through, because your hands would be knowing. So as you pass through those vertebrae, you know that okay, pierce this, as it passes through those ligaments, right? So you know that now you have passed through the supraspinous ligament, and now you are passing, and then ligamentum flavum, and then there would be a free space, right? You keep on going more, the dura is tough. The moment you pierce the dura, right, there would be a popping sensation, that popping sensation, and that's where you know that now you are into the subarachnoid space, right, till that point. And because say that needle is having that stillet, so you just take it out and see that is there is any leakage of the fluid, because when you are into the epidural space there won't be any leakage of fluid, right? Nothing will come out, so you can go further, and then the dura is tough, and then as you go tuck, right, that would be popping sensation. And now when you take that stillet out, you'll find that drop by drop it will start coming up, so that is when you collect it, right? Good question, right? So that's how we get this, right? Do remember these important points. Almost all these points, they are the part of some. So you will definitely, na? Because see, dura is so tough. That's why when you pierce it, right, you'll feel, your hands would feel that resistance. And the moment dura is pierced, right, the movement of the needle, that will become very smooth, right, because it has popped and it has entered into chamber. And now when you take that stillet, because this entire needle is hollow, you'll find that fluid is coming out, right? So that's how it happens. Okay, the next one, this is intervertebral disc herniation, right? Herniation. The commonest site, right? Which are the commonest site? The commonest site is say L4, L5, L5, S1, right? This is very common. Lumbar and the cervical, right? So commonest C5, C6. This is very common, and C6 and C7. Nowadays, you'll find that C5, C6, C6, C7, that has become pretty common. Reason? Cell phones. Seriously, cell phones. Because when your head is tilted, right? So it generates, because now just at that point, the entire load of the head is on that point, right? So gradually it is, because it is like a constant pressure. So nowadays you'll find that in youngsters this thing is seen more commonly. Lumbar, L4, L5, L5S1, the commonest reason, bad posture, right? When person slumps, right, झुक के बैठते हैं, right, in chair, they sit like this, right? This is the commonest area. That is where the whole pressure would be mounted. When this happens, What exactly is herniation, right? What exactly is herniation? The key word is, it is the, see, we learned in anatomy, right, that this is the intervertebral, this is the intervertebral disc. This one is what? Nucleus pulposus, right? Nucleus pulposus, because it is pulp like, it is soft, right? And surrounding is annular. Annular means circular, right? So these are the annulus fibers, right? So when these fibers are degenerated, so any of the degenerative changes, so over here, right, these are like degenerative annulus fibrosis, right? And that leads to that nucleus pulposus then enters into the vertebral canal, right? And when it enters into the vertebral canal, so that's the nucleus pulposus, right? Nucleus pulposus. So now this is herniated. Herniated means it goes into, right? Goes into vertebral canal. But in the process, right, as it goes, it compresses the nerve. So compression is root of one nerve below, right? So remember this, compression, it compresses root of one nerve below. All are questions, right? One nerve below. So do remember this. And which ligament will be involved? Well, it has to be posterior longitudinal ligament. You know? So let's take it like this. This one, right? See, this is what I'm talking about. Okay? This one, that one, right? So that one would be posterior longitudinal ligament. Hmm? See this one. This is the MRI. How nicely you can really see the things, right? So this is MRI of herniated intervertebral disc, right? Which is the pink color substance? Pink color substance is nucleus pulposus, right? This one is nucleus pulposus. Okay? And it is the nucleus pulposus which herniates. Right? It is the nucleus pulposus which herniates and leads to compression. Okay, now this is like abnormal curvatures, right? Abnormal curvatures of spine. Three curvatures. One, what is called as the kyphosis. Second, what is called as the lordosis. And third one, what is called as the scoliosis. All are very specific. When we say kyphosis means this is the normal curvature, right? A smart, beautiful S-shaped. But in kyphosis, it is the thoracic. So this is the thoracic curve, right? This is the thoracic curve, right? Then we have got the lumbar curve, right? That is the lumbar curve. Right? And then below is the sacral. In kyphosis, thoracic curve is involved, right? So that's the keyword, that thoracic curve is involved. So how the things would look like? As if there is a hump in the back. Hump, right? There is hump in the back. So this is hump or the protrusion, right? Protrusion in back. That is what is called as the kyphosis, right? You'll find that normally this occurs in elderly people. It occurs in elderly people. Why elderly people? Right? That is because of the osteoporosis. So in elderly people, it is because of osteoporosis. Porosis. But when you see it in young, once again, it is that hump, right? It is that cell phone. Recently, I came across a person and he said that I said that do you waste 1 hour or 2 hours on cell phone? He said, sir, 6 hours, sometimes even more than that, right? So all those habits, they can actually lead to this kyphosis. So here the bad posture, those, it is such a bad thing, bad posture, right? So please always, that's why it is said that when you stand, right, pull your shoulders back, pull your shoulders back slightly. When you sit, sit straight, right? It will help you a lot as you will progress in your life, right? Okay, moving on to the lordosis. In lordosis, all you have to remember is because over here the lumbar curve is involved, right? Lumbar curve involved. Think it like pregnancy, right? It's like pregnancy. So over here, this is a normal curvature and this is how the curve goes, right? Because the lumbar curve, this is the lumbar curve, right? That is involved. So one that is physiological, that is pregnancy. Why it is necessary that post pregnancy exercises, they are very much needed, because see, this is a normal physiological process, but after that, right, this curve should go back, right? This curve should go back. That's the reason that strength training is so important. Otherwise the pathological, say, spondylolisthesis, right? Spondylolisthesis, all these things, right, they lead to, because see, this is a pressure zone, this is the area where there is so much of pressure. So any of the wrong pressure, right, that can lead to, say, this lordosis. And the scoliosis, in both these cases you are watching from the side. In scoliosis, if this is the body, right, this is the body, this is the vertebra, right, but that's normal. In scoliosis it goes sideways. That's the vertebral column. So there is lateral movement, lateral displacement, right? Lateral displacement of the vertebrae, right? That is in spondylolisthesis. That is all this. That I've not spoken much about, because otherwise we'll remain in spine only. But basically, what happens is the disc space and the vertebral bodies, right? They start getting involved. There is formation of osteophytes, and it gets weakened, and that leads to, say, wedging. Wedging is this. Say this is the body and this is what is called as wedging. Wedging. That's called as wedging. And it is this wedging which leads to compression of nerves, at the same time formation of this lordosis. Now this lateral displacement, it is because commonest is poliomyelitis, right? Poliomyelitis. And when you see any patient of scoliosis, chances are very high that he or she might be having some hip disease. So in that case, say for example, avascular necrosis. So in avascular necrosis, that head, right, there is loss of blood supply to the head of the femur, right? So when that portion is involved, it is painful. So that's why person will try to put the more weight on the opposite side, and gradually it leads to scoliosis. But do remember, kyphosis, thoracic curve; lordosis, lumbar curve; scoliosis when it goes laterally, right? And in scoliosis, the commonest is poliomyelitis or the hip disease, right? And in case of kyphosis, the osteoporosis, the commonest one, right? Okay, moving on to this. This is CA breast, carcinoma of breast, a major killer, right? Can be, scoliosis can be congenital, right? It can be congenital. because all these topics, right, kyphosis, lordosis, scoliosis, they are huge topic in themselves. So when we'll be talking the orthopedics, right, at that point all these topics will be coming in great detail. But this is in general something which, if anyone wants to pass the USMLE step 1, these are the keywords which are needed, right? Otherwise, so there can be so many reasons. But yes, scoliosis can definitely be congenital, no doubt about it. It can be. Acha. So moving on to the carcinoma of breast. In carcinoma of breast, the keyword is, it's also called as the adenocarcinoma, right? Adenocarcinoma. From where it develops? It develops from, now see, in breast there are lactiferous ducts, right? Milk producing ducts. So they are the lactiferous, or let me write like this, epithelial cells, right? Epithelial cells of lactiferous ducts. Lactiferous ducts. Now in anatomy, we studied that these lactiferous ducts, right? There are supportive ligaments and they are called as the suspensory ligament, right? They are called as the suspensory ligament. Suspensory ligament, full name is suspensory ligament of Cooper. In case of carcinoma of breast, this suspensory ligament of Cooper is involved, right? So these ligaments, they are now shortened. Now see here, because this is one image where you can actually watch, say this one is the mass, right? So that is carcinoma. Say these are the suspensory ligaments. This one, right? Then this one, right? These are the suspensory ligaments. So when the mass is involving those suspensory ligaments, those ligaments, they got shortened, right? So they are shortened. When they are shortened, it leads to classical description and what is called as the puckering of the skin. The word is puckering, P-U-C-K-E-R-I-N-G, puckering. This is what is called as puckering. This is what is called as puckering, right? So that particular skin that is pulled inside, right, irregular. So this is very important and it is due to suspensory ligament of Cooper when they are shortened, which leads to puckering, right? The moment we talk about carcinoma of breast, the important thing which comes is about the lymph node, right? Very commonly asked. Okay, so let's say lymphatics of breast. I'm trying to make things as simple as, when do they suggest breast removal? We'll come to this, right? I have put that topic also, right? We'll come to that, and because it is associated with what is called as the mastectomy, and it is associated with few very important points, right? I mean, many times asked in multiple competitive exams, not only the USMLE, but even the USMLE PLAB, even in our FMG exam, and very common. Okay, coming back to this breast, right? The entire breast divided into lateral and the medial half, right? Lateral half and the medial half. The lateral half, right? This is almost 75% of the lymphatics, right? It comprises of 75%. It drains into pectoral, all those various types of, but finally it goes into the pectoral, and from pectoral it goes to the axillary lymph nodes. Axillary lymph nodes, right? When it comes to medial, because that's the reason it is so important that where exactly the mass is, right? When it comes to medial half, so it will drain into parasternal lymph nodes. Parasternal, that means they are near the sternum, right? Parasternal lymph nodes. Or it drains onto the opposite side, right? It drains into the opposite side. So that's the reason that any of the medial side involvement, it is very easy to get, say, opposite side involved. This is about 25% of the lymphatics, right? So do remember this important difference. What you asked, right? The mastectomy. It is also called as the something in this case. It is called as the radical mastectomy. Radical mastectomy. Right? It could be unilateral. It could be bilateral. Right? It could be unilateral or bilateral. Now, when do we go for mastectomy? One very simple thing. We figure out that there is, from the CT scan, from the plain X-ray, from that is what is called as the mammography, right? Mammography is the examination of the radiological examination of the breast, right? In which you are taking X-ray, but the entire KV and the MPS, they are totally different, because now you are looking at a soft tissue. So there is a special machine, right, in which the breast is sandwiched between two plates, and then the X-rays are taken. Okay, so from the various quadrants. So in mammography, if the breast is examined and then it is figured out that yes, this is carcinoma, you go for whether the lymph nodes are involved. You go for CT scan, you figure out whether the lymph nodes are involved or not, right? And you find that still the metastasis mats, or the metastasis, right, it is not present. So in that case, it is very much necessary that we go for mastectomy, so that at least we can stop the spread. So in radical mastectomy, what is done? The breast is removed, right? Pectoralis major, right? Pact major, that is removed. Fat, then lymph nodes, right? Lymph nodes, right? They are removed, right? Now, this is all okay, but when you are doing it, the moment you say that you will be removing the pectoralis major, there would be one important artery which will be going, right? And that is the thoracic lateral thoracic artery, and we have seen this artery during our dissection, right? Full long this long thoracic artery, this has to be ligated, right? So to be ligated. Now what really happens, that as you ligate this artery, as you tie this artery, right, there is a very important nerve which is very close to this, and that nerve is long thoracic nerve, right? That one is long thoracic nerve. Now, if this nerve is also tied along with it, so that is damage. Any damage to this will lead to what is called as winging of scapula. Winging of scapula. What is winging of scapula? Winging of scapula is when the patient tries to press, right, those scapula, inferior end of the scapulas, right, they will be coming out as if it is like patient has got wings, right? This is because of just one muscle. Again, it is like a question, right? That muscle is serratus anterior, right? It is serratus anterior. This is the muscle which is involved. This is serratus anterior muscle. What would happen, right? Okay, it's fine, the winging of scapula, right? Winging of scapula, this muscle is involved. But what would be the disability? Disability is when the patient will try to abduct the arm, right? So arm abduction more than 90 degrees, not possible. This would be the disability, right? So when we talk about radical mastectomy, so long thoracic artery, which is to be ligated because it is one of the procedure which that is to be done. Take care of long thoracic nerve, right? So lateral thoracic artery involved to be ligated, long thoracic nerve is to be spared. That's why it is called a spare, right? That means don't damage. Spare the long thoracic nerve. If involved, winging of scapula, muscle involved, serratus anterior, and what would happen? Arm abduction more than 90 degrees, gone, right? So that is That is what is important associated with radical mastectomy. The procedure, radiological procedure for breast examination, it is called as the mammography. Came from the word mammary glands, right? Graphy means imaging. So imaging of mammary glands is mammography. It requires specific, different machines. It is not the machine which is used for the normal X-ray, right? So a specific machine and a specific procedure. When we'll be discussing, say, radio in more detail, right? I'll show you the various mammographic plates, right? Normal and abnormal. Because in that quadrant is very important. In which quadrant, when you find that there is something, some mass that is called a space occupying lesion, so in which area that mass is. Okay. Infection of the breast, it is called as the mastitis, right? Mastitis. So whenever we talk about infection, right, we talk about infection, there would be pain, there would be swelling, there would be increased temperature, right? These are all cardinal signs, right? And there is redness. These are the cardinal signs of inflammation, the inflammation which is because of infection. Now, mastitis, normally, the infection is in the cases of lactating mothers, right? So that is very common, and usually it is lactating mothers. Usually it is self-limiting, right? Not much is to be done, and it takes care of itself. But how it really happens, that see, baby's mouth, right? Baby's mouth, via baby's mouth, those bacteria, right? Those bacteria, they enter via cracked nipple, via cracked nipple. That's the reason that it is very much necessary to lubricate the nipples very properly so that they don't crack, right? So via those cracked nipples, infection goes inside, right? And then it spreads into the area. So usually this happens after 1 to 3 months of breastfeeding, right? Months of breastfeeding. But if the proper care is taken, it never happens, right? So that's why this is, and even if it occurs, the procedure, the treatment is not that complicated. Okay, we now talk about diaphragm, right? We talk about diaphragm. In diaphragm, commonest diaphragm, diaphragmatic palsy, right? That is diaphragmatic palsy. Why it should occur? One simple reason, the phrenic nerve, right? Phrenic nerve injury. This phrenic nerve injury, it can be unilateral or bilateral, but in most of the cases it would be unilateral. Unilateral. When it is unilateral, that means only that side of the dome of the diaphragm would be affected. Now we know that's like thorax, right? And then during the breathing, right, this is the thorax, and then there is a diaphragmatic movement, and it goes like this. So yeah, so diaphragm is paralyzed, dome of the diaphragm, that half of the diaphragm. Okay. So when we, so this is like resting, and when we breathe in, right, inspiration, so there is, right, the size of the chest increases, it goes higher, and the diaphragm is lowered. True, right? Diaphragm is lowered because we want to increase the chest size, right? So in expiration, the, or the, I would say, normal expiration, right? Normal expiration, or during our resting phase, that is when the diaphragm goes below, and during the inspiration, sorry, it goes up, and in the inspiration, normal inspiration, this is normal, right? The diaphragm goes down, right? This is normal. Over here, what really happens is this, right? So that's the thorax, right? And the diaphragm goes like this. So this is during inspiration. So during inspiration, diaphragm goes up. This is what is called as the paradoxical movement, right? Paradoxical movement of the dome of the diaphragm, right? So during inspiration, dome, that is affected dome, goes up, and this can be seen radiologically, right, very easily. So that's the important point. So do remember this part one, and do remember this, that phrenic nerve, that is what is getting injured, right? And that's what really happens in the diaphragmatic palsy. This is injury, right? This is injury. Here also, this is diaphragmatic rupture. I have kept this thing just for one reason. This is diaphragmatic rupture. Diaphragmatic rupture, it is because of commonest reason, it is blunt injury. Blunt injury's commonest reason is almost 80 to 90% of the cases, that is the vehicular accident. Right? So almost 80% of the cases it is due to vehicular accident. When this thing occurs, two things are asked. Which side is the commonest affected? The left side is commonly affected. Right? So why so? Well, when we draw, right, when we draw it like that, okay, this is the esophagus, this is the stomach, and then duodenum, right, jejunum, ileum, right, everything goes, then this is the appendix, this is the cecum, and the ascending colon, transverse colon, descending colon, and then we say, let's draw the liver, and we draw the liver like this. And where would be the spleen? The spleen would be, the liver would be up to this point, right? That's the liver, and spleen would be over here, because spleen would be, how the spleen? This is the C loop. From here the pancreas will go, tail of the pancreas, that's where the spleen would land, right? But see, the important point is that on the right side there is a big liver, right? So that liver can take the impact. So that's the reason that this rupture of the diaphragm, it is more common onto the left side. Do remember, left side, it is more common, right? Left side. Now, as it is seen over here, right? As it is seen, see, this is the rupture, right? This is the rupture. And from here, the abdominal contents, they have gone up. So much so that this is the lung, right? So left lung is compressed. Left lung gets compressed. So much so, it can lead to pneumothorax also, right? Because when it's broken, so obviously the pleural cavity would be affected and can lead to pneumothorax, thus worsening the condition. So that's the diaphragmatic rupture. Now, when we say this, right, just I'm talking about, say, cardiac hypertrophy, right? Cardiac hypertrophy. You come across a patient of mitral stenosis, right? Mitral stenosis. So when it is mitral stenosis, it will lead to what? It will lead to left atrial enlargement, correct? Right? It will lead to left atrial enlargement. When you see this and you find that patient is complaining of dysphagia, that is difficulty in swallowing, right? Difficulty in swallowing. So when it is difficulty in swallowing, first procedure which you must do is either you go for CT scan, right? Either you go for CT scan, or as a very quick procedure, because barium swallow, it takes it doesn't take much time, right? And it is not only cheap, but it is pretty fast, and you'll be able to see it instantly. It is the, you are suspecting esophageal compression. Esophageal compression. Investigation of choice should be barium swallow. Barium swallow. And in this barium swallow, you'll be going for the lateral plate, right? You won't be able to see much on the say PA view. Possible, right? You might get a nice curve like this, but when you go for the lateral X-ray chest, it is conclusive, right? So do remember this. It is a lateral X-ray chest. Barium swallow is the investigation of choice when the patient is having dysphagia and then there is left atrial enlargement, right? Maybe because of mitral stenosis, and we'll see that in case of mitral stenosis, where exactly should you auscultate, right? We'll cover that part also. So that's what important is. Now see, when we say this, you must know that when we draw the heart, right? When we draw the heart, right? So this is the right side, this one is the left side. So in case of right side over here, this is superior vena cava, right? This part, it is the right atrium, correct? What about the left heart border? This bulge, that is because of the arch of aorta. And then just underneath, below, you have got the pulmonary trunk, right? Pulmonary trunk. And then you have got the left atrium. And then below it, you have got the left ventricle. And this one would be the apex. So that's the reason that when there is left atrial enlargement, right? When there is, we'll complain about the taste. Not, the taste is not very much. Taste might not be very much affected. When a patient will be having left atrial enlargement, it was what is called as the straightening of the left heart border, right? Because as it enlarges, it becomes straight. So left atrial enlargement radiologically on simple plain X-ray chest, right? It is straight left heart border, right? So this is what you must know. Though we have discussed this thing, but still I thought of, okay, chalo. So when we talk about auscultation, right? When you take the stethoscope, and what should be known to you very properly is which are the major areas, right? Which are the major areas. So let's say this is our heart, right? Right? That's the heart. That would be the sternum, right? In between. So that would be the sternum. I know people would scold that tomorrow is Valentine Day and we are drawing the heart in this shape, right? But at least for the understanding for today, keep the heart in this shape, right? So this is right side, this one is left side, and we have got four major areas. One is the aortic, right? So that one is aortic area. This aortic area, it has to be on parasternal line. So that's the sternum, and parallel to sternum on the right hand side into the second intercostal space. So in second intercostal space, that is aortic, right? So this area, that one would be aortic, parasternal, right side, second intercostal space. So what about the pulmonary? Well, that is pretty easy, right? This one. So that one would be the pulmonary area. Pulmonary. So that pulmonary would be on the left side again. Now onwards we'll write parasternal line as PSL, right? So it will become easy. So on the left side, it would be parasternal line, again, second intercostal space. Easy. Then comes Then comes our tricuspid, right? So tricuspid would be here. So this is tricuspid. Tricuspid is again parasternal line, right? But in fourth intercostal space. So done. Finally comes the mitral area, right? So mitral area, that one would be the mitral area. That is different, right? Over here, we'll be dealing with mid clavicular line, right? Mid clavicular line. Do remember this, because whenever you'll find things are a bit different, that's where the questions arise, right? So it is mid clavicular line. And which space? Well, the space is now fifth ICS, intercostal space. Bus. Do remember these four areas. Because these are very specific points. Now, when we are talking about heart, right? So, regarding the blood supply, right? Blood supply, very specific, very specific questions are asked. Now, see, in blood supply, we know that there are two: right coronary artery, right, and the left coronary artery, right? Right coronary artery and the left coronary artery. Do we have a page for? We have. Right, right coronary artery. In right coronary artery, first important branch, right, which is like going, so that is the anterior cardiac branch, and that anterior cardiac branch will be supplying right atrium, right atrium. Then there are very specific, which we discussed as nodal branches, right, nodal branches. So there would be nodal branch for SA node, there will be nodal branch for AV node, right, very specific. This one, to remember, putting a star, right. Then there was our all-time favorite, marginal branch, right, marginal branch. So marginal branch will, right, going on the margins, and it was giving right ventricle, correct. And finally, the main one, right, which is also called as the posterior interventricular, right, interventricular artery, right. We discussed this in that coronary circulation and the coronary angiography in so much detail. And this posterior interventricular, so this is, if this is interventricular septum, right, that's the portion it supplies. This portion is what? It is the posterior part, right? Posterior 1/3 of interventricular septum, right? These are very specific questions, right? And what about other things? So let's change the color and put it as plus. So it supplies this posterior interventricular septum, posterior 1/3 of interventricular septum, plus it goes underneath, right? So that's where it is the inferior surface of right ventricle and left ventricle, inferior surface, right, the base. So this is like blood supply and of heart, I mean right coronary artery, right coronary artery, right? We need to talk about left one, left one. So left coronary artery, very easy, divided into two parts, right, divided into two parts. One is left anterior descending and second one is circumflex, right, circumflex. And we draw the figure, right, because it becomes easier to remember. So this is the portion. So this is what? Interventricular septum, and it supplies anterior 2/3 of interventricular septum, right, plus it will supply what? It will supply bundle of Hayes, correct, bundle of Hayes. So this means that SA node and AV node, that is by right coronary artery, and then from that point onwards it is by the left coronary artery. So bundle of Hayes, moderator bands, right, this was one of the question, huh? Moderator bands, they are supplied by, well, moderator bands, they are supplied by LED, right, plus the anterior wall of heart and the apex, obviously the apex, right, plus the apex. What about circumflex? Well, widowmaker, right, we That was, it supplies left atrium, it supplies left ventricle. Can't miss it, right? These are the two important. And plus anastomose, right? It anastomose with right coronary artery, right? So that's how the whole thing is. Two things to be remembered, that when it comes to the conduction system, right? The conduction system of the heart is supplied by both the arteries, right and left, right? Then they can modify the question in any way they want, but we remember that this is SA node and AV node by the nodal branches of RCA, right coronary artery, and rest of the things, his bundle of his moderator bands, Purkinje fibers, all those, that is by the left coronary artery. Right? Now we talk something about lungs, right? We start with the trachea, right? And what we are trying to discuss is the aspiration. Very common in case of kids, child, when they swallow something, right? So in that case, if we see the trachea, right? The trachea goes something like this, right? We don't find much of the difference, right? This is the right side, this is the left side, but the point is that right side is at a very smooth angle. So any of the foreign body, right, as it goes, it will easily slip into the right side as compared to the left side, because left side is at an angle. So which is the commonest side affected? Well, the right side, any of the aspiration of foreign body, that is very, very common, right? In case of kids, in case of children, right? They aspirate and it goes into the lungs. So right side is common. Why should you really know this? Because when you take the X-ray, right, you watch for this first. As it will go, in which lobe it can really enter? Well, it can enter into middle lobe, but more common into the lower lobe. And if the patient is in vertical posture, right, and he swallows something, so in vertical posture, because that's what really happens, right? That bacha is sitting or standing and swallows something. The commonest lobe which you will watch, that is, this is a question, right? Posterior basal lobe is the commonest lobe. That is, in fact, segment, right? Posterior basal segment of lower lobe. Now this is okay, right? That is the commonest involved. So this is the thing. Watch for this X-ray, right? This is pneumonia, infection, right? Pneumonia. So pneumonic consolidation, that can be seen. Now this pneumonia is what? Lung infection. Simple, right? It is lung infection. And infection could be bacterial, it could be viral, right? It could be viral, it could be fungal, right? How to diagnose all of them? Well, that is purely the medicine part. Right now we'll try to see what is more important to see in this case, right? How the patient would present. Patient would present in the form of, say, there would be cough. Makes sense, right? There would be difficulty in breathing, dyspnea. That is because now the alveoli are involved. Chest pain. Yes, that is infection, right? It is giving pain, right? And there would be fever because it is infection, right? So that's why these are the important signs. On X-ray chest, this is what you see. The opacity of lung parenchyma. So you will see the opacity, right? Opacity in lung parenchyma. Now see this opacity. If you watch closely, right, so there is presence of air, right? But one important thing which we see in this case is whenever there is infection, those bronchomediastinal lymph nodes will be enlarged, right? So bronchomediastinal mediastinal lymph nodes, right? Mediastinal lymph nodes, LN stands for lymph nodes. They will be enlarged. Now, because they are mediastinal lymph nodes, so it leads to, watch over here. Doesn't it look like the mediastinum, the whole mediastinum has widened, right? So this is the infection along with involvement of mediastinal lymph nodes, which leads to mediastinal widening. Mediastinal widening. Well, some of the things which I'm explaining, they are part of second year or even third year. But once you see it, it gets registered in your brain, right? So it becomes much easier as you proceed, right? Because we'll be watching lots and lots of such cases as we'll be discussing the medicine or radiology. But once it has been said that yes, see, compare this mediastinum. I think there is one. Compare this mediastinum with this next case. Right, immediately you will find that this is where the mediastinal widening. See, this is the mediastinum, right? And watch it over here, right? That is the mediastinal widening. Okay, coming on to the next case. Now this is definitely, right? Just look, this is bronchogenic carcinoma, or the C of lung, right? Bronchogenic carcinoma. From where it develops, right? Simply from the mucosa, of large bronchi, right? From large bronchi. That's where it arises, mucosa of lung. And what would happen? Well, cough, but one of the important thing, hemoptysis. That is, blood would come out. How will you differentiate it with hematemesis, right? Why were the arms in the air? Means where you are talking about this case. This is a kid. I think you are talking about this, right? And the arms are up. So baby was held like this. So this is hemoptysis. Hemoptysis, whether the blood is coming from lung or blood is coming from stomach. That is called as the hematemesis, right? Yeah, clavicles are at an angle. That's true. So when it is coming from stomach, right, so it is called as hematemesis, the vomit of blood. When it is hemoptysis, so it is coming from lungs. When it is coming from lungs, so then blood would be associated with froth. Blood would be with froth. And when it will be hematemesis, that blood would be a frank blood, right? Because it is coming straight away from the stomach, right? So here it would be from the froth. Now, whenever it is carcinoma, so metastases are very common. Metastasis, right? Secondaries, that is very common. And metastasis, right? This metastasis is commonest into the thoracic nodes. First, that thing metastasizes into thoracic nodes, and that from that point it spreads. Right? So here is a tumor, right? That's a tumor, a big tumor. Now there is a specific name if the tumor is over here, into the apex, right? Into the apex. So if the tumor is into the apex, right? I'll say tumor in apex. So the name given is, it is called as the Pancoast tumor. Pancoast tumor. Now this Pancoast tumor, if it is there, that will lead to what's called as the thoracic outlet syndrome. Thoracic outlet syndrome. So it means this particular tumor will be occupying the position between the clavicle and first rib. Now, when that thing happens, right, classically, there would be pain, right, because now there will be involvement of this is the apex, plus the nerve involvement will come into picture, and immediately it will lead to pain into the shoulder, pain into neck, right? Then there would be numbness in fingers, right? Numbness in fingers, right? Numbness, weakness, all those things would start, right? So this is what is called as the Pankos tumor. One more question, right? One of my students, she asked this question just I think day or two back. You know about the ligament. Let's take it on other page. You know about ligamentum arteriosum, right? Ligamentum arteriosum, right? That is the remnant of ductus arteriosus. So that is when it goes like this, right? That's the pulmonary trunk, and this one is arch, and then there is ligamentum arteriosum. What happens, or the which nerve is involved when there is a space occupying lesion? When there is a space occupying lesion near to ligamentum arteriosum, and that is left recurrent. The answer is left recurrent laryngeal nerve. Left recurrent laryngeal nerve. Right? That is when there is SOL, space occupying lesion, in zone of or in the area of ligamentum arteriosum. So left recurrent laryngeal nerve is involved. That's it. Only this much question was asked. But see, when left recurrent laryngeal nerve is involved, what happens? Right? It leads to vocal cord palsy. Right? Vocal cord palsy, or the paralysis of vocal cords. Now, this thing I have discussed in more detail in the section when I talked about larynx, right, in head and neck. So actually which muscles are involved, how it really happens. But the symptom, it is the hoarseness of voice. Hoarseness of voice. So that's the reason why you should be super sharp, because you are talking about space occupying lesion, and when you see the patient and patient's voice is so heavy, right, you know this is hoarseness of voice, and definitely there is involvement of the RCN, right, recurrent laryngeal nerve, right? So that's one of the question. Do keep it in mind, right? Okay. As we were talking about what? Auscultation, cardiac auscultation, right? Over here, we were talking about cardiac auscultation. Let me write cardiac auscultation. Right? Similarly, we need to, no, this is not the question of exam. I remembered it. So when we say auscultation, so then there has to be the lung auscultation, right? So in lung auscultation, what you hear, you try to hear the breath sounds. All those variations, right? All those variations like wheeze and stridor and all those, they are basically that when sometimes when the patient is breathing, you put the stethoscope and you sing like that type of sound, wheeze, right? So all those are variations of the normal breath sounds. But where exactly to auscultate, right? This thing should help you a lot. Say the right side, whenever you do the right side, and the left side auscultation, right? Left, right, or left, right? So right or left, superior, middle, and inferior. These are the lobes, correct? For the superior lobe, right, when you are auscultating, right, above fourth rib, any of the change in the breath sounds on the right side, when you auscultate, you know that this is superior lobe which is involved. In case of left, above sixth rib, above sixth rib. For the middle lobe, right, now you go down, right, you go down. So between fourth and sixth rib. So now you know that it is the middle lobe of right lung is involved. Obviously, here though it is not applicable because on the left side there is no middle lobe. And for the inferior lobe, it is the posterior chest wall, right? Posterior chest wall, right? Same over here. So this is in nutshell, that's where you will hear all those breath sounds, right? Acha. Regarding the pleura, because there was one email, so let me clarify it very easily. For the pleura, there are two types of pleura, right? One is what? Parietal, and second is visceral, right? Parietal and visceral. One fundamental thing, and that is that visceral pleura is sensitive to only stretch. Yes, right? So it is sensitive to stretch only. Stretch only. While parietal pleura, right, it is sensitive to the pain, it is sensitive to temperature, it is sensitive to touch, it is sensitive to pressure, right? All pressure, all sensations. Right? So, okay, when we are talking about this, let's take the nerve supply also, right? That would be easy. So let's change the heading to nerve supply. Otherwise, so it is why it is sensitive to stretch only because it is part of ANS and how it is getting supplied by the pulmonary plexus, right? So by pulmonary plexus. But what about the parietal pleura, right? Do you remember parietal pleura was having three parts, right? So there is the costal parietal pleura, then there was the mediastinal parietal pleura, right, which is on the mediastinum. One was the costal, right? One was the costal on the inner part of the thoracic cavity. Then another one which was the medially situated mediastinal, and third one was the diaphragmatic, right, just above the diaphragm, right? So diaphragmatic. Now you know, right, parietal pleura, which covers the entire lung. So that costal, who will be supplying? Because it is carrying pain, temperature, touch, pressure, everything. So it has to be by intercostal nerves, right? Intercostal nerves. Mediastinal pleura, well, phrenic, right? That's the nerve. That's the nerve, phrenic nerve. What about the diaphragmatic? Diaphragmatic is very specific, right? Diaphragmatic is this is the dome, right? And this dome is on both the sides, right? Right dome, left dome. So this is same for them. The middle of the dome, this is middle. That is by phrenic, right? That is by phrenic. And what about the circular sides? That is by, right? So if we watch from the top, it would look something like this, right? This is the middle portion, that is by phrenic. This one's by phrenic, and rest of this, that is by lower 6 intercostal nerves, right? So this is done. Yeah, this image I put it. This is the aortic aneurysm. This is because one of the email, how aneurysm looks like. Well, aneurysm is what? Aneurysm is abnormal dilatation, right? This is abnormal dilatation of walls of aorta, or any of the blood vessel. Here we are talking about aorta, that's why. Otherwise, it can occur in even other arteries also. But, but over here, though this is not thoracic, this is abdominal aorta, right? This is abdominal aorta, abdominal aorta. And to be very frank, this is the commonest site. See, this is just before bifurcation. See, this is the right, and this one is the left common iliac artery, right? See the bifurcation, right? So this is the commonest site where the aortic aneurysm can really occur, right? So bifurcation of aorta, commonest site, commonest. The commonest complication, right, that is aortic, this aneurysm rupture or the acute rupture If it occurs, well, the mortality rate is very high, almost 90%. Because of the pressure, the moment it ruptures, the blood loss is so high, so it's almost. And what would be the treatment part, right? How it is treated? Well, if it has not ruptured, so then surgery. And in surgery, what is done is it is called as the prosthetic graft. It is called as the prosthetic graft. That is what is put, right? So that it covers and it gives the protection. So this is, yeah. So this was for today. That's it for today, right? From next time, we'll be starting with neurophysiology, right? So thank you so much. Right. And why does it occur? So many reasons, so many. It could be because of pressure, it could be because of some congenital anomaly, multiple reasons. And this, right? Happy Valentine Day, very in advance. So see you day after tomorrow. Thank you and take care. Bye-bye. I'm putting this file into our folder. Neurophysio should be over by the end of this month. Thank you and take care. Bye-bye.